All right, so we're going to move into utilization management and authorizations. So the questions we look to answer in this section is what is utilization management, what is the purpose, why is it needed, because I'm sure you have questions around that. And then again, with conversations with your colleagues, this was also similar to eligibility, kind of their next lesson learned is how to prepare for the authorization process when you're working with the MCOs. So we'll get into that a little bit and talk through what some suggested changes might be or some processes that you're going to want to put some additional thought into with your current practices. So there's several types of utilization management. There's prospective, which happens before. There's concurrent, which is happening while. So many times concurrent is happening during an inpatient stay. So during an inpatient stay, the MCO is communicating ongoing with like the discharge planner and the case managers at the hospital. So that's an example of concurrent review. And then Lindsay touched a little bit on retrospective review when we were talking about claims. So that's done retrospectively. So after you've submitted a claim, they're looking at billing information on the claim, what the procedures were done, the documentation, things of that nature. We are specifically going to focus on prospective, which is known as the prior authorization process. So that's what our session this afternoon is really going to focus on. But I just wanted you to be aware that depending on the type of services your agency delivers, you may be involved in multiple types of utilization management. Okay, so the what and why of prior authorization. So prior authorizations is prior approval, so advance approval of services. So this is something that you have to do before you give the service. If you try to do it after, you're going to run into some barriers because the whole nature of it is to get approval for the service before you do it. So that's really important. They're going to ask you for specific procedure information and maybe for specific medications. So there's a variety of reasons or a variety of services that require prior authorization, but the whole goal of it is that you're getting approval prior. What happens at the MCO level is they're really looking at determining evidence for the service, the clinical practices around the service. Is it the right care for that client or member at this time? So remember, many times as the MCO, as you heard from Aunt Martha's earlier, many times the MCO knows more about what's going on with that member than you may at your individual clinic at that time. So they're looking to prevent duplication. Maybe they know of services that already happen with that member, that would be information that they would share with you or interactions. Or maybe sometimes they want you to do a different service before you jump to another service, for example. And many of us have had that even on the commercial side with our own care. So that is kind of why they're doing the prior authorization process. And if you also think about the payment structure for an MCO, the MCO is who's at risk for the member. So if you guys so if you think about what happened with managed Medicaid is the state transferred the risk from themselves of managing the members. They transferred it to the MCOs. Now the MCOs have the risk, meaning they get their set payment and they're figuring out, they're instrumental in determining how they're going to use those dollars and how we're going to improve quality and reduce duplication. So the risk is with the MCO, which is why there's kind of this push-pull between providers and payers, right? Because the payer is at risk, meaning they're financially at risk for all the services done for this member, and they're trying to manage the quality for the member at the same time that the different providers are wanting to provide care to the same member. So the whole basis of insurance is around the risk. And you also heard from Aunt Martha's how they've started to assume risk, right? So as a provider, you can move down that track, which eliminates some of the burden of authorizations because now you're taking on the risk of that member. Now that's a journey. I wouldn't recommend jumping to that. I always show it as a stair step. You want to take on incremental steps, but the whole premise of authorizations is around the risk in which the payer has at the time. All right, so there are contractual requirements around authorizations, because many times you'll hear that you don't hear back from the MCO, or that it's preventing you from providing appropriate care for the member. But the MCOs are contractually required to respond within 4 days from receiving a request up for authorization. They can ask for an extension of another 4 days if it will not harm the enrollee, but with that extension. But so you will hear back on any authorization within 4 days, and they're contractually obligated to do so. Did someone have a question? Oh, sorry. All right. Okay, so you may be asking, when is an authorization required? So each MCO, this is not something we've been able to standardize, and we'll probably never be able to standardize, because each MCO, the nature of their secret sauce is how they manage care and their care coordination model. So standardization around that is probably unlikely, but they do all have tools to help you navigate the authorization process on when and what an authorization may be required for. Some of the tools are better than others. Some have what I call a code checker, so you can actually put in the CPT code and it's going to tell you yes or no. Some have lists, but they all have some mechanism to communicate to you how and what an authorization is required for. And I really encourage you to use these tools so you're not frustrated like this individual on this cartoon here, because many times I just think for efficiency purposes and for your own sanity, if there's tools available, I would highly encourage you to use them. And these code checkers and lists are helpful and can help your staff as you move into the authorization process. The providers, as we've mentioned throughout, or the MCOs, as we've mentioned throughout the session, also have provider portals. Once you contract with an MCO, you're going to want to register for their portal. All their portals look different. They all require different things for you to register for them, but just put that on your checklist as you contract with the payers, start signing up for their portal. Now, what you're going to want to understand is what you can do with each portal, because that will also dictate for you operationally what processes and where to intersect with the portals for which members. They don't all offer the same functionality, and some of them, I don't know, how many of you have used the provider portals before? Anyone? Yes, some of them are easier than others, would you agree? Yeah, some of them are helpful than others, but the reality is they're there. Figure out what's in there and how to integrate that into your processes for your own efficiencies. So for this example, they all offer member eligibility verification. So in addition to Meta, you could also look in their portal for member eligibility. Some of them you can submit your prior auths right into the portal, and they're going to notify you right in the portal. Again, some of them do that better than others, so you're going to want to do a little test on how you want to use this. Sometimes you'll also be required to submit additional information for an auth. So you could submit an auth, and they're going to ask for clinical documentation for certain things. Some of the portals can handle receiving that documentation, and some of them cannot. So again, it's just a matter of getting a good understanding of what each MCO's portal offers you and how to navigate those in your own operations. So how to prepare for prior auths. Again, it's really important that you have a mechanism for your team to know where to look for what's required and what's not required for an auth. Understanding the portals is going to be important. Facilitating that into your operational process. I think two of the agencies we met with said the one thing that a large lesson learned from them was changing their clinical staff to be documenting the right clinical information at the right time, because when an MCO would ask them for some clinical documentation, many times it wasn't sufficient what they were documenting. So you're going to hear this afternoon, that was one of the lesson learned from Turning Point as well, so I guess we had 3. And just that additional training and understanding from your clinical teams on what is necessary in order to have that thorough documentation that's going to be requested. And then knowing where the most efficient way to request the information. So where can you find it? Do you go to the portal? Do you have to call? What is it, and how will you operationally do it? Talked about that. This little clip here is from the AMA, and I didn't put this here to scare you at first. I think it was a little bit scary. But what we wanted to show you is what we heard from your colleagues is that this isn't something that can just happen by chance. Integrating prior authorizations into your operations is something that has to be very deliberate, both from your clinical perspective and an operational perspective. So who's going to follow up? What if you don't hear in the 4 days? How are you going to proceed with the care? Because if a service requires an auth and you do not have the auth, you will not get paid for the service. So there's really no leeway in that because there just isn't any leeway. You won't get paid. I don't know what to say. So this was just to show you, this was a study the AMA did, but it really is showing you that it has to be a deliberate process. If it's not a deliberate process, then you won't be successful in getting paid from your MCOs for these particular services. So I don't want to, it was controversial me putting this in here, but again, it wasn't to scare you or to burden you. It was just to let you know that it's really important that you have a very deliberate process in order to work through the authorizations requirements. So there is a controversy around auths. Again, I've been both on the provider and the payer side, so I'm well aware of the arguments on both sides. But this all boils down to, again, that earlier conversation around risk. So when will auths go away? They'll go away as the risk transitions to different entities, right? Because right now the risk is with the MCO, so they are determining what does and doesn't require an auth. Now, the MCOs will go through their auth requirements about every quarter to 6 months and determine what needs an auth. So don't always assume you want to use those checkers because they will update that information. I know on the team that I was managing at the time, we would go through and see how many approvals we were doing. If we were always just approving a certain type of service, why do we have the auth? We're not requiring clinical documentation, it doesn't necessarily align with the guidelines. So we would take things off the list. Sometimes if we were having a problem with services, they might come on the list. So the MCOs do take some deliberation around what's required and not required. And as the risk transitions to providers, if that's something you're interested and excited about, that's when some of the authorization requirements go away. So I don't know the details of Aunt Martha's risk contract, but my guess is if they are taking risk, then they have more say in what services they do and don't do, because again, that impacts not only the quality for the member, which they're measured on, but the cost of care for that member. All right. All right. What questions can I answer about authorizations and utilization management? I know it's not a fun topic. No questions? Oh, Carrie, there's no questions about UM. They got this. Oh, okay, good. Wait for Carrie.
I was just wanted to ask, you put like the 4-day, but does it vary for inpatient, outpatient services? We mainly do inpatient. Obviously, if we're getting a referral for inpatient, you can't wait 4 days for an authorization.
Right, there's different ways you can, I think in the contract, expedited versus non-expedited. So if you're in a situation, then you would want to submit as expedited, because then they have different criteria for that. But a general auth is 4 days.
I would say for things like, someone shows up in an emergency room in crisis and the determination is they need to be admitted, you can ask for an expedited, and I think they have to turn that around within 24 hours.
Right.
I think the four-day time frame were things like, you're having a hip replacement, like planned events
services.
and planned surgeries. Or you want to change a medication, although that's all changing now because we've got universal PDL. But the 4 days is really more for those planned services where you can always ask for an expedited review and they have to get back to you within 24 hours.
Yeah. And that's contractual as well.
Yeah.
So let's say we're receiving a referral from an emergency room and we're the referring hospital. Do we have to wait to get an approval from that MCO prior to taking the patient, or how does that?
Well, it came through your,
It's not through our emergency room.
not through your emergency room.
So they want to transfer
For
because they don't have
two-year
inpatient
facility?
psych or something.
Right, we're in a psychiatric facility.
Yeah, I don't want to get into, like, I don't want to speak for the MCOs, but generally speaking, you're going to want to know, you want to know that it's an approved transfer before you would accept it. But I mean, I don't know each clinical
Yes,
situation is
it's
different, so I don't want
different,
to but yeah, in general, you're going to want to make sure, and in some cases, like I know like long-term care, the burden for the referral is on the receiving entity versus the transferring entity. So you need to work out those logistics depending on the type of facility that you are, for sure.
Thank you.
Yeah, I would highly recommend that.
Okay, you mentioned using a provider portal to see if authorization is required. That's not always so.
Yes.
Unfortunately, with Illini Care, it'll say on the portal it's not required, but they'll deny the service for no auth attached.
For the auth attached.
For not having an authorization.
Oh, attached to the claim?
Right.
But does it, and it requires an auth?
Not on the portal, no. I'm getting a lot of those from Illini Care.
Is it denying for no auth, or, because that's important to know, even, it could
Yes.
deny for other reasons?
No,
The
no
auth?
authorization.
Yeah. I don't know. I think though that's a situation when you definitely want to work with your provider rep and give them those examples. You will see on the portals when you do, it will tell you that an authorization is not a guarantee for payment. That's the disclaimer on every MCO's portal, because there could be other reasons. That's why I asked her if it was denying for auth. It could be other reasons the claim denies outside of an authorization. So just because you have the auth doesn't mean that the service is going to be paid.
Yeah, and then
But I think in your situation, if you have the auth, it says but if it says it's not required and you have the auth, I don't even understand that. But maybe Carrie can help you navigate Illini Care. Yeah.
I can help
situation.
with some disputes if
Yeah.
we need to, if it's not accurate. But
Yeah.
yeah, I'm sorry about that. We'll talk about it.
Yeah, for sure. Any other questions on auths? Okay, we're wrapping it up.